Hello, everyone, and welcome to Talk Nerdy. Today is Monday, January 29th, 2024, and I'm the host of the show, Cara Santa Maria. And as always, before we dive into this week's episode, I do want to thank those of you who have made Talk Nerdy possible. Remember, Talk Nerdy is and will always be 100% free to download. And in order to keep this kind of keep the boat afloat, I rely on support from different sources. So obviously I sell ads in the show. Ad sales have been abysmal lately, as you've probably noticed for most podcasts. So really the biggest contributor to the show is Patreon support. It's episodic support from listeners just like you. If you're interested in pledging your support, all you've got to do is visit patreon.com/talknerdy. This week's top patrons include Daniel Lang, David J.E. Smith, Mary Neva, Brian Holden, David Compton, Gabrielle F. Jaramillo, Joe Wilkinson, Pasquale Gelati, and Ulrika Hagman. Thank you all so much. So, okay, let's just dive right into the show. This week, I was lucky enough to speak with Dr. Uché Blackstock. Now, she is an emergency room physician, and she's also the founder of an organization called Advancing Health Equity. And their goal is to partner with healthcare organizations to dismantle racism in healthcare and to close the gap in racial health inequities. So today we're going to be focusing on a new book that she wrote. It's called Legacy: A Black Physician Reckons with Racism in Medicine. So without any further ado, here she is, Dr. Uché Blackstock. Well, Uché, thank you so much for joining me today.
Thanks so much for having me, Cara.
I am excited to talk about your new book. I'm also excited to learn a lot more about you, which we will be doing through kind of talking about your new book, because it is sort of, so Legacy: A Black Physician Reckons with Racism in Medicine. Would you say it's sort of half memoir, half advocacy or like social justice, or really more than that, just like the science of kind of race inequity in medicine?
Yeah, I mean, I think it's a little bit of everything. So, I always say like it's a generational memoir. There's also a lot of history in it. So, for history buffs, people will love that part. And then also there is that social commentary advocacy component too. So, I always say it's like a memoir with benefits.
I love that.
Because you get that extra bit that you don't typically have in a memoir. I want people to like read Legacy and to feel like, one, oh my goodness, I learned something, even those folks who think they know everything. And then two, I want them to leave reading it feeling like galvanized and electrified to actually do something about racial health inequities.
Yeah. I'd love to start off, I'd love to know a little bit more about, your journey before you got into, I'd say like before you went to medical school, because obviously, as the title implies, legacy, this is something that you kind of always, or at least for most of your life, knew you were just going to do, right?
Yeah. So legacy has that double meaning. And one meaning of it is the fact that, I am a second generation physician. My mother was a doctor. And so I feel like there was always this implicit understanding that my twin sister and I would become doctors. And I think part of it was just also because our mom was just this amazing woman who had, not the easiest childhood, was the first person in her family to go to college and then medical school, and was, our role model. We wanted to be just like her. So I feel like from a really young age, I kind of like thought, okay, I think it's just good. I'm going to be a doctor. And, I really didn't think about anything else, because being a doctor for me felt like, something very intellectually stimulating. I would always be learning something new, but also I would be able to work in service to my community. So it was just like the cherry on the top.
And also it sounds like, and of course, this is kind of one of the points of all of this, it sounds like it was just normal, like it's what you knew, right? And I think when we talk about representation, or we talk about mentoring, or we talk about visibility. Part of the reason that it's not normal for Black women to be doctors, it is still like deeply underrepresented, is because that representation isn't there. Like when you said, legacy has a double meaning, of course, you were going to come up to become a doctor with your twin sister because your parent was a doctor, went to Harvard.
Exactly.
Most people are like,
Right.
oh yeah, her dad. Like most people would,
Right.
oh, your mother? It's not what people first think of.
Yeah, and honestly, like it was the only thing, like you said, it was the only thing that I knew. Like that was normal to
Mm-hmm.
me. It was normal, obviously, to have a mother who was a doctor, but not only that, my mother was, the head of the local group of Black women physicians. So my mom would always take us to those meetings when we were little girls, and so we would sit in back of the room and listen in on this group of Black women physicians doing amazing work. And so I always joke that growing up, I thought that most physicians were Black and were Black women. I didn't realize until I got older that we actually are only like 2.8% of all physicians. But in a way, I feel really grateful that that was the norm for me because it made me realize that that was a possibility.
I remember, if I'm being 100% honest, like, and my friend Emily just posted this online. I remember being completely stumped when I was a little girl by that riddle, right? And you probably know this riddle, and probably everybody is now primed to actually see the answer. But when I was a kid and somebody would tell me, okay, so a man and his son get in a car wreck and the man dies and the son is rushed to the hospital and the doctor comes in and says, or the surgeon comes in and says, I can't operate. That's my son. Who's the surgeon? And everybody's like, I don't know. I don't know. Who could it be? This is so confusing. The father died. And it's like, obviously it's the kid's mother. But
Right.
nobody
I know.
like when we
I
were kids,
know.
we were so stumped by that. That's so gross.
It really is. And I realize like that is probably what is normal for like the majority of people, like that they don't have a mom. Like, I always say that like my sister and I are unicorns, and it's something that I'm proud of, but I also feel like shouldn't be the case, right? Like to say that I'm a physician and my mother was a physician too, and we're Black women. Um, it's like I said, it's super, super rare, but like there's a reason for it, and I get into it, in the book. Like it's not because there's something inherently wrong with women or Black women. It's because there are and have been systemic barriers and policies and practices that have kept those numbers low. And like that's what I wanted to like help readers like connect the dots with. Like, I think that there are a lot of things that we take for granted. Like we see these percentages and we're like, oh, that's really bad. And we don't really think about why. Like, why is that the case? And so that's what I hope this book does.
And so tell me a little bit more about your kind of path going in. Were you a biology student? Did you already, you kind of always knew you wanted to go to medical school. So did you go through pre-med? Like what did you do to sort of set your
Yeah.
trajectory?
Yeah. I mean, I just feel like even when I was, 12 years old, I was doing summer science programs. Like I knew that I was super interested in science. I knew that I either wanted to be an MD or MD PhD. Like, so it's either or. And then I realized that, the more that I kind of observed patient care, I realized I kind of wanted to lean more towards doing clinical work, working with patients. And so I went to a math and science high school, Stuyvesant High School, in New York City, which is, it's been around for a very, very long time and is known as one of the premier science high schools in the country in New York City. And so I think after going there, I was like, for sure, I want to apply to medical school eventually. And so I was pre-med at Harvard. I majored in biology and then did my pre-med courses. Although in retrospect, I kind of wish I had probably majored in anthropology or sociology and then also done pre-med, fulfilled my pre-med requirements, because I realized like that was the last time for me to learn learn about other disciplines. And I realized also so much of what I do now around, health equity and racial health inequities, it involves like understanding how societies work and how systems work. But anyway, so yeah, so I went to Harvard undergrad, was biology pre-med there. I really enjoyed it, but as I talk about in the book, during that time, my mother was diagnosed with acute myelogenous leukemia. So unfortunately, college was not like the exciting experience it should have been, because I was also balancing my pre-med courses with coming back down from Boston to New York City to visit my mom while she was getting her chemotherapy for leukemia.
Yeah. And so kind of shuttling or I don't know what the right word is, but sort of finding yourself in a position where you were having to grow up pretty quickly, having to kind of balance the really demanding academic load along with this like kind of deep personal thing that a lot of kids, I mean, let's be honest, a lot of kids at that age don't have those kinds of pressures, but a lot of kids at that age do. You know, a lot of kids at that age are their family's provider. A lot of kids at that age are, dealing with deaths in the family or dealing with conflicts within the family. But that's a lot, did you have to take any time off, or did you kind of push straight through?
That's such a great question, because my mother, being my mother, said, I know that this is a really difficult time, but I want you to try to finish school on time, finish college on time. And if you need to afterwards, you can take time off. And I think she was worried that if we took time off during college, that maybe we wouldn't go back, or we'd be so devastated we wouldn't go back. So Oni and I, my twin sister, we actually stayed in school. We would come down to New York City on the weekends and sleep in the hospital room with her, and then go back up on Sunday evenings to Cambridge and like resume our college life. And so I think at the time we were just in survival mode, because our mom was like she was just full of life, vibrant woman. She ran every day. She ate well. She lived life to the fullest. And so, this idea that now she was debilitated at only the age of 46, like she was so, so young. We definitely wanted to be there as much as we could. And we would be doing homework, we'd be doing our coursework in the hospital room while her oncology team was making, rounds on her and talking to her. And I think for her, being a physician and then being a patient was very difficult. It was very, very
Oh, I can
difficult.
imagine. Yeah,
She
I think that,
understood.
yeah, being on both sides of that is incredibly challenging. How when you were in school with Oni, were you guys taking like all the same classes? Were you able to kind of be there for each other, kind of step by step?
Well, Oni actually was a computer science major. She was
Oh, okay.
computer science and pre-med.
Hmm.
So she really, really wanted to challenge herself. But we were roommates all during college except our freshman year, because Harvard doesn't allow twins to room together. Even though our mother requested it, she said, "Please, I don't really want to have to buy them two of double everything. It would be much more convenient if they could live together." But we were roommates from sophomore year to senior year, and so we were really able to support each other. It's amazing having a twin, because you have someone who absolutely gets it, especially when you're going through a difficult time. Like we madly in love with our mom. We just loved her so much, and so it was difficult for both of us, but we were there to support each other.
Yeah. And so ultimately you finished your undergrad, you went to medical school. What was your residency in? Like what did you choose to specialize in?
Yeah. So, it was actually during my first year of medical school that I realized I was interested in emergency medicine, because one of my anatomy instructors was also an emergency medicine physician at Mass General Hospital. And so, which is one of the Harvard teaching hospitals. And so he basically said, if anyone wants to shadow me, come along. And so one night I spent a shift with him in the Mass General ER, and I got to see just how exciting emergency medicine was. That you actually, like on one shift, you could see someone coming in with something as benign as a cold to someone coming in with, in cardiac arrest or a trauma patient. And I really appreciated the unpredictability of it, but I also really love the idea of, in the ER, you help everybody. Like, it doesn't matter what their insurance status is. It doesn't matter why they're there. Like, I think the idealistic part of me was like, you're there to help them. And so I ended up applying in emergency medicine for residency. And it was interesting because at Harvard, most of the students go either into internal medicine or surgery, more of the traditional subspecialties. Emergency medicine is considered a newer specialty. And I remember my attendings, my supervising physicians asking me, are you sure you want to waste your Harvard education on going into emergency medicine?
Oh, no.
Yeah. And I was like, yeah, I'm pretty sure I do. I don't think it's a waste.
Jeez. What was it like for you when you actually, spent that time face to face in the ER and you really started to realize like what you had signed up for?
Yeah. I mean, I think when you're in medical school, you're young and idealistic. And I definitely, when I started my residency, so for residency, I came back to Brooklyn, New York, to, neighborhood where I grew up in to do my training. And so I was at a public hospital, so one of Brooklyn city hospitals, and then SUNY Downstate, which is one of the State University of New York hospitals. So it's a university hospital, but both of them are pretty underserved. And it was really challenging because, I went from the Harvard teaching hospitals that have a tremendous amount of resources, that are well staffed, that are modern, new, and at Kings County, the city hospital in Brooklyn, where I was doing my residency, we were always understaffed, right? Never enough nurses, never enough doctors, never enough medical technicians, never enough radiologists. And it was really hard. It was really, really hard. And you felt like you just wanted to do what was best for your patients, but you felt really constricted by the lack of resources.
How did you cope with that? I mean, was this sort of one of the important inflection points for you to start to see the inequities and start to see some of the systemic failures in medicine? Or were you not quite in social justice mode? Or had you always sort of been thinking about those things?
Yeah, I think I was always in social justice mode. I just never, I didn't like, so for example, like, growing up in my neighborhood in Brooklyn and Crown Heights, I always like recognized that, there were a lot of abandoned buildings. We always had to go to an adjacent neighborhood, Park Slope, to find a decent grocery store. My parents never felt comfortable sending us to the public schools in our neighborhood. And so I never really understood why. And then I started connecting the dots that a lot of like my neighborhood was a formerly redlined neighborhood. So it was a neighborhood that in the 1930s had received a very low rating by the Federal Housing Agency, FHA. And because of that, people living in that area were not able to qualify for mortgages or mortgage insurance. And so my neighborhood essentially was chronically disinvested in. And I started making the connections, like working at Kings County, that there were these connections between what we call the social determinants of health, education, housing, employment, and how healthy people are. So I would see my patients coming in, and many of them were having, food insecurity, unable to, find or purchase healthy foods. They were having housing insecurity, couldn't afford their rents, difficulty finding employment. And and that was all actually impacting their health because many of them were uninsured, right? We know, in our country, most people have health insurance that's tied to their jobs. So a lot of people they had jobs where, even if they did have jobs, those jobs didn't offer benefits. So I was like, connecting all the dots during my residency. It still wasn't all clear to me, but that was definitely the beginning of this journey to focus on racial health inequities for me. Like I talk about in the book, a patient named Jordan with a history of sickle cell disease who really through my experiences with him, I recognized how larger systemic issues like racism end up impacting health. So like Jordan was in his 30s, had sickle cell disease. Like he was always in the ER. He's what people would call a frequent flyer. Like we would see him all the time. He would come to the ER in a pain crisis. So pain in either his arm or legs or his chest, which is very typical of people with sickle cell disease. And I always wondered, why do we see so many patients with sickle cell disease in this ER here in the middle of central Brooklyn, mostly Black patients? And what I came to find out is because a lot of funding has not gone into researching sickle cell disease. Like, so even though sickle cell disease was first described over 100 years ago, because it had been racialized as a Black disease, and that's only because in the US, most people who have sickle cell disease are Black, even though people from all over the world have it. But because of that, there hasn't been a lot of research. There hasn't been a lot of funding given to sickle cell disease, unlike other hereditary diseases like hemophilia or cystic fibrosis, which afflict mostly people who are racially white. And so I was like, the reason why Jordan is always in the ER is because we have a system that doesn't take care of him or take care of the disease that he has. And so what we're seeing is the manifestation of that in these frequent visits to the ER, and that actually turn into this issue of patients with sickle cell disease becoming stigmatized as, seeking drugs or seeking pain medication in a way that is like suspicious. The fact that people are coming in pain and you're wondering, are they really in pain or do they want pain medication? But that's how I was trained. Like I was trained to be suspicious, and recognizing that they were coming there because their disease was not being well managed.
I feel like this is a story that I've heard specifically about sickle cell so many times. It's like that kind of extra layer of you're already struggling with this incredibly painful and debilitating disease. And now on top of it, you have the whole kind of psychosocial layer of what are they going to say? Are they going to turn me away? Are they going to be cruel to me? Like, how do I go in and be as authentic and genuine as possible so they believe me? And I'm super curious. I've been seeing documentaries recently and talking to individuals in, like, let's say OBGYN about cesarean rates among Black women, or pain being dismissed among Black women, or infant mortality being higher. And of course, different specialties kind of have their specific examples. And obviously your sickle cell patient is such a telling example. Are there any other things that you regularly saw sort of in the ER that are very ER specific, that were just massive reminders for you of health inequity?
I think so. I think like the issue that you bring up about pain, and that's an extension of like the sickle cell disease conversation, is one that has been around for a while, but hasn't received enough attention. And I think because it's often difficult to maybe quantify, people want to say like, okay, wait, what do you mean people's pain isn't being treated properly? Like the whole idea of not knowing how in pain someone is causes health professionals to doubt them, because they can't actually look at.
You can't measure it. Yeah.
Exactly. So pain is one of those tricky areas, and it shouldn't be tricky. But I was actually been doing some work over the last year around what we call like pain inequity, because we do have studies that have shown that often Black patients in particular, their pain often goes untreated or undertreated. And so people say, well, what does that matter, right? Like, okay, well, when you're in pain, that causes both emotional and psychological distress. But often there is a reason why someone's in pain. There's some underlying diagnosis that if you don't dig deep enough, that you're going to miss. So that could result in a delayed diagnosis, a misdiagnosis, harm, or even death. Like, I've spoken to patients who were turned away multiple times from the ER, or their complaints about, chest pain or pain somewhere minimized. And then it turned out that they actually had something very, very serious that was almost even life-threatening. And so, so we see that often around maternal health, but we also just see it more broadly. And so one thing that, I often talk about is that a lot of people say, well, why does this happen, right? Why are Black patients' why is it being undertreated? And I will say that I think it's because of their deeply rooted false beliefs and myths about Black people that actually started, during slavery. So, this idea, and I talk about this in my book. So there were, for example, J. Marion Sims. He's known as the father of modern gynecology, and he experimented on enslaved women. He made these very, very useful discoveries. He discovered the vaginal speculum, and he also discovered ways to fix what's called vesico-vaginal fistulas, which are connections between the bladder and the vagina that happen after childbirth as a result of injury. And so he made these really important discoveries, but he did so by using and experimenting on enslaved Black women without even using any anesthesia.
Who clearly couldn't consent, and clearly,
right, who couldn't consent. But then I think that it falls into this idea of biological essentialism, and that's how slavery was justified. That there are different. That's how you had to find a way to justify it, to say the reason why one human being can own another human being is because that other human being is not really fully human. And so we see that in terms of even people who were physicians, like Dr. Sims, he also, what was an enslaver? He owned, human beings. But in order to do that, you have to make them less human. And so I think that, unfortunately, a lot of those beliefs and those myths, honestly, they get passed down from generation to generation, whether people realize it or not. And there was a study actually in 2016 at the University of Virginia where they did a study with medical students and residents, and they gave them two cases. The cases were exactly the same. One patient was white, one patient was Black, and they asked the students and residents to rate the patient's pain and to come up with treatment recommendations. And the majority of the students and residents, they gave the Black patient less pain medication, and they rated their pain lower. And
because of this deep belief that somehow either they're lying or they can handle it.
Exactly. Right. And the other thing was these authors also came up with these false beliefs. They made up these beliefs like Black people's skin is thicker, Black people's skin is less sensitive. And they asked the residents and medical students, are these true? And they found that the students and residents who were more likely to believe these false beliefs were also more likely to undertreat the pain in Black patients, in the mock patient. And they were also more likely to not think the patient was in as much pain. So, and that's 2016, right? And these are doctors in training. So, it's hard to talk about this because I think that every person who takes care of patients wants to say, I am doing my best. I am treating all of my patients the same, but that's not always what happens.
And it doesn't always happen, let's say, cognitively or overtly. A lot of this stuff is sort of unconscious bias. We can say that, of course, there were overt and verbalized stigmatizations, lies in historically, and it still does occur. But I doubt you're going to find a passage in a medical book that says Black Black individual skin is thicker. But you're going to hear some little comment by an attending or some little thing by a nurse or and like those things become ingrained. Like there are these little hints and these little nods, and all of those things collectively become this implicit bias.
Exactly. And then the other thing is that, one thing I also write about in the book about is this idea of what's called a race correction factor. So what I learned in medical school was that in terms of kidney function, there are different kidney functions for Black patients and non-Black patients. And that was based on this different normal values. And that was based on this idea that, or this myth that Black people had a higher muscle mass, and that muscle mass, the creatinine that's broken down from muscle is related to kidney function. So this is what I was taught. This not only was taught that, but when I use the electronic medical record, I see that there's actually a note in the lab values that this is the normal range for Black patients, and this is the normal range for non-Black patients, right? So that's something actually that, has changed in the last few years, because there have been nephrologists, kidney doctors advocating for a change in that, saying that this is based on a myth, because what happened as a result of those differences in normal values is that Black patients were less likely to be referred for specialty care for kidney disease. And they were less likely to end up on the kidney transplant list. So we have to really think about, like, what are the consequences of these ideas that Black patients or Black people are somehow biologically different. But even just like seeing that in the medical record, right, these differences in normal values, that has to have an impact on health professionals, saying like there's something biologically different. There's even in pulmonary function tests, so that's the lung function test, there's also a race correction factor in that as well, because that was based on the physician who originally developed the lung function test said that Black people have different lung capacity than non-Black people. So again, these are ideas that have actually crossed generations of like physicians and medicine, and still like current day exist, and that what we're grappling with and dealing with.
And I think that probably a lot of people who struggle confronting the harsh reality, and who kind of, there's a psychological protective mechanism that says, I don't want it to be true that this is such an entrenched problem, is I think they try to sanitize in their minds. It's a natural psychological kind of approach to say, okay, yes, there are historical wrongs that say different, or like, it really like rings like separate but equal to me. But what we often don't realize or don't want to admit is that a lot of these documents, a lot of these statistical descriptions, they come from a place of eugenics. They come from a place of white supremacy. It's not just, Black people have this value and it's different. It's Black people are inferior and this is why. And like early, I come from psychology. And so that's a huge part of our field, is grappling with the fact that most of the celebrated early psychologists who did brilliant things statistically, that statistical contrasts are named after, did these things. They developed these IQ tests. They did all this really sophisticated stuff to prove the superiority of white people. Like that was their goal.
Yes. Yeah. I mean, and I think that it's so important that we have these conversations, no matter how uncomfortable they are. And I think, you mentioned unconscious bias, and, I always like to use unconscious bias in tandem with, systemic racism together, because I think there's this belief that because it's like unconscious, that it's less harmful. You know what I mean? Like, but the problem is that it is harmful, and it can, when health professionals say like, I didn't realize it, I didn't realize I was thinking this way. But the fact is that that it was happening. It was impacting the way you're treating your patient. And what that does is that actually perpetuates the systemic inequities, So what happens between a health professional and a patient, right? Like, is super important. Although we know systemic factors have the biggest impact, but still what happens in that exam room, what happens in that clinic is so incredibly important, right? Because we know that clinical decision making is key in how well a patient does, right? And so you want to make sure that patient is truly being listened to. And, just because it's unconscious or there may be bias that's unconscious, it doesn't mean that it is any more benign or less harmful to patients.
I actually think in some ways it's more harmful because it's harder to uncover and it's harder to change. Like, I can't help but be reminded of the quote. I've talked about this on the show before in other contexts, but I feel like there's a connection here. The quote from Martin Luther King in Letter from a Birmingham Jail, where he talks about basically that it's not the Klanner, it's not the white citizens counselor that he's so much more afraid of. It's actually the white moderate. It's the person who's sort of like shruggy, who says like, I just want a passive approach to justice and it should happen on the timeline that nature takes its course. No, like that's why this stuff continues, because people go, oh, they don't mean it. It's not intentional. And yeah,
right.
like that's the problem. The overt like neo-Nazi is easy to point out and say, okay, let's not be that guy. It's the more subversive stuff. I think I'm much more concerned about that.
I'm so glad you said that, because I think that's absolutely correct. Because I think often sometimes, like when you say it's unconscious, people are like, well, it's unconscious. What am I supposed to do? It kind of absolves them of accountability. It absolves them of responsibility. But what I think, because I do this work a lot with the consulting firm that I have, Advancing Health Equity. We work with healthcare organizations around bias and racism in healthcare. But part of the work we do is definitely trainings are important. So to really start having these conversations, these I call courageous conversations. But also we talk about what are strategies that you can use in your interactions with patients to mitigate those biases, one, but also two, we also know there needs to be practices and procedures and like protocols in place systemically, like within the electronic medical record system that keeps track of how, for example, how opioid or pain medications are prescribed, and the hospital is doing, is looking at metrics and seeing, are there differences in how, patients of color are being prescribed medications versus white patients. Like, there really needs to be processes in place. Like, for example, I was working with one of my clients. It's a well-known academic medical center, and they found that Black patients were waiting 80 minutes longer to be admitted to the hospital than other patients in the ER. I know.
Yeah, I mean, there's no justification for that. And there's no reasonable explanation except for systemic racism.
Exactly. And so we talked about what are things that we can do. So one thing was, we can develop a dashboard for each health professional so that, every quarter they can see how they're doing compared to their peers, one, or compared to the standard. Two, maybe we can put reminders in the electronic medical record system. Like, for example, if a patient's been waiting 30 minutes, it blinks on the screen. So just like thinking about different processes that we can put in place to mitigate these biases, because it's one thing for someone to go through a training, and we know, and as you know, like people probably need, long-term multiple trainings to undo these unconscious biases, right? So that's why we need systemic processes in place to help them.
Yeah. I mean, I say all the time, sometimes I feel like a broken record when I'm talking about anything. I mean, it doesn't even have to be about these social justice topics, but about critical thinking or just any neuropsychological humility, all these different approaches that I often focus on in my work and on my show. And I'm like, oh, I've said this 100 times now, it's getting old. No, sometimes you have to say something 100 times before it's heard. And I think we sometimes forget that. Like, it can't just be one and done. It doesn't work that way. There's something that comes up for me that I'm super curious about. Obviously, your book is called Legacy: A Black Physician Reckons with Racism in Medicine. You are a Black physician, but you're also a woman. And the intersectionality kind of component of this, I think, is really fascinating. So racially, I'm white. I'm a white woman. I present white. Everything about me has white privilege. I'm Latina, but that's my ethnicity. You wouldn't know it by looking at me. So my mom's Puerto Rican. And I think about intersectionality a lot. I think about the fact that I am a woman. I think about the fact that I, sometimes identify as queer. I think about the fact that I had a hysterectomy. I am a cancer survivor. I have, all these different aspects of who I am and how that makes me me. And when we think about massive systemic inequities, especially in medicine, I can't help but think about not just race, but gender as a massive issue. And so I'm curious about that component of your reality and your experience and how that plays in, being a Black woman. It's not additive sometimes. I think that kind of intersectionality, not that we're talking about like oppression Olympics or anything, but that kind of intersectionality is multiplicative. That's not even a word, but it's that much. You've had that many more barriers, and you see that much more difficulty with Black women, but especially like, let's say, Black queer women or Black poor women, or whatever the case may be.
Yeah. It's interesting because there's this. I write about it in my book. This theory called like pet to threat. I don't know if you've heard about it, but this idea that when a Black woman or a woman of color enters an organization, like initially, the people are like, "Oh, you're so amazing. We're so happy to have you here." And then once that woman starts speaking up and pointing out things that need to be changed within the organization, they actually become a threat. And then they become isolated, and people tell them that they're problematic. So it's almost like, they want you there. I talk about this in the book. Like, I was I was handpicked for this diversity, equity, and inclusion role at the medical school at the academic center I was at. I was super excited to be in this role because actually the reason why the role was even created, it was because a survey had shown that there were huge gender disparities in terms of perceptions about, being mentored, being sponsored, and being promoted. Like, when junior women faculty just felt like they were not getting the support they needed. So they created this role, and I was super excited about this role. And it turns out, like, I was actually it was like a figurehead role.
Yeah.
They kind of like the institution
kind of, yeah.
Yes. Yeah. They just kind of wanted to say, okay, in response to the survey, we created this position. But what happened was I was super excited about getting the role that I actually came up with all these ideas and initiatives that I wanted to do. And initially I just got shut down. And it just made me realize that a lot of times, a lot of these efforts, whether they're around gender equity or racial equity, oftentimes they can be very performative. And it was so incredibly demoralizing for me. But once I started speaking up, I was doing work around gender equity and against sexual harassment, I actually became a threat. Like, I was told, you're becoming too political. You're,
as if your life is politics. That's
right,
the thing. It's such a privileged thing to say, I'm not political. It's like, well, that's because you're in the majority and all the laws favor you right now.
Exactly. Yeah. And so and my social media was being monitored. Like, I literally felt like I was under a microscope. And I think that's often that. And at the time I felt incredibly isolated. Like, I felt like I was the only one going through this, but I think it's something that's actually really, really common in corporate America or in academic medical centers. I think that, there are these environments where we go into and we're super excited to be there, but people are not necessarily excited to have us speak up. They kind of just want us there, just be representation, but don't say anything.
And also to say I approve of what the administration is doing. I'm proud of their effort. It's like
Yes,
a way for them to get off the hook about things.
exactly.
Ugh, how
Exactly. I
how
know.
incredibly frustrating. And then I think the sad thing is what ends up happening is that women, individuals of color, these intersectional people who have a point of view, and that point of view is not a political point of view; it's a personal point of view. This has been my life experience. They end up being shut down in places where there is no space for that kind of honest and critical discourse. And so they end up finding places where they feel safe. So you have these little silos of like really progressive and inclusive spaces, but they're all quote alternative.
Well, that's what happened with me. So I eventually decided I'm going to leave. Like, I'm leaving this career that I built for 10 years in academic medicine. I thought I would stay in academics for my entire life. Like, I never thought that I would leave. And actually, like, I actually went through a grieving period when I realized that it was untenable for me to stay because I couldn't show up authentically. I couldn't talk about the issues that I cared deeply about. And so then I decided to leave this like position that people looked at me like what's wrong with you? I had multiple titles, but I felt misaligned. I felt like I was in an environment, like I said, where I couldn't be myself. And so I left and I started my own consulting firm. And I had like a 5-year plan that I was also working part-time in urgent care. So, which was considered like a huge demotion from being in academics. But I knew that like that's what I needed to do. But then summer 2020 happened, BLM, the pandemic happened, and it just reinforced the need for the work that I wanted to do. And I've been busy and working ever since. So I left this environment where I couldn't show up as myself, and I created one for myself.
Which is incredible. And I think what a brilliant approach to kind of doing this on, with advancing health equity, which is your organization, and also like, speaking across multiple platforms, consulting with individuals who are open to learn, because there is that sort of, I guess, position of representation. My concern is when people find themselves going, and not that this is a bad thing, but going and working in like more community medicine or going and working in more community organizing, and basically only finding themselves making a difference in places where the people are already open. The people are already realizing that there's a problem. And then you have these institutional places. It just becomes more and more siloed. The problem gets more and more entrenched because they're pushing out anybody who has an alternative point of view.
I know, and I feel so conflicted about it because well, are you saying that everyone should leave like you left? And
Right. And
I
it's like, oh,
okay,
no,
and
of course.
and of course not. I mean, I feel like ultimately you have to do what's right for you and for your well-being. Like, of course not. I mean, I think that if you're someone who can work within those environments and it not be incredibly harmful to you, then do it. Because I feel like we need to be in those spaces also. But I knew
Don't
that
kill
I had
yourself
gone
doing it. Yeah.
right,
Like,
exactly. But yeah, but I knew I had gotten to a point where I was like, okay, like I'm losing weight. I have bags underneath my eyes. I can't sleep. Like, this is not a healthy environment for me. I'm going to have to find an alternative.
yeah, I mean, it's the same thing I often say when I'm working with like LGBTQ youth. Like, I did my internship for my psychology degree in Florida. I mean, this is a place where kids couldn't be themselves legally. And so it's like when we're talking about, be loud, be proud, it's like only if it's safe to do so, like don't put yourself in the line of fire because that's what you see as the right thing to do. It's such a difficult and very personal decision. Like, safety first. Like, if you're not safe, how are you ever going to actually be effective? But what a sad thing that so many people are grappling with such a fundamental, what I believe is a human right, the right to
Yes,
safely speak.
yes, yes, absolutely.
Mm. And so, I'm curious now. Obviously, we're running low on time. We've sort of followed the arc of your training, of your the conflicts that you've not just seen, the inequities that you've not just seen, but felt personally yourself, and how they've actually affected your career. So I'm curious about the future. What is the ultimate goal, let's say, for the book? Obviously, it was probably a cathartic experience for you, but also you wrote it for other people to read it. So what are you hoping people take from it? And also, what are you hoping that your work now, where your work takes you?
Yeah, I mean, I always say I wrote this book for a broad audience, that this is not just for people interested in medicine or healthcare or science. This is a book that anyone who is committed to equity and justice should read, because I think it's going to help them connect the dots on how we arrived to where we are today, where, for example, Black birthing people are 3 to 4 times more likely to die of pregnancy-related complications, and where the United States has the highest maternal mortality rate of any high-income country, but we spend the most on healthcare. I want people to understand why this is happening. And at the end of the book, I have a call to action. I have a call to the last chapter is a call to action for different groups of people. It's for white folks, for institutions, for hospitals. I want people to understand, you can play a role in changing things. You can play a role in making sure that we have a more equitable society. So that's my goal, is that people read this and are galvanized to take action. And then for me, in terms of next steps, I don't even know. I mean, literally this book, I've been working on it for about 2 years.
Yeah, so you're do I need to do something else? Can I just relax?
I know. No, but I'm really excited about the reception that it's going to receive, the conversations that it's going to make. And what I would really love is actually to start working around policy, whether that's on a local, state or federal level, because I talk a lot about how we can improve health by thinking about health more holistically. And that looks like changes in housing policies, education policies, employment policies. How can we just make our communities healthier? And it's not just about what happens inside of, like I said, inside the exam room or the clinic room, that we have to think.
Right. There's a lot that happens.
Yes,
leading up to that point. And you've got to make those connections.
Yeah. So I would love to do more work on the policy front.
Oh, I love that. Well, gosh, everybody, the book is Legacy, A Black Physician Reckons with Racism in Medicine by Dr. Uché Blackstock. I cannot thank you enough for being here with us, for sharing your insights, your time, your story. It's been educational. It's been informative. It's been, I think, in some ways, really kind of motivating. And I've just really enjoyed talking to you. So thank you so much for being here.
Thank you, Cara. I really enjoyed our conversation also.
And everybody listening, thank you for coming back week after week. I'm really looking forward to the next time we all get together to talk nerdy.